I believe so. Brianne, Jillian, you have no objections to sharing the slide deck after the presentation?
No.
Yeah, sure. Happy to
Great.
share.
Wonderful. All right. So, Brianne, if you can go to the next slide, we can start at least with some of the introductions while people are filtering in. Lauren, if you're still there, I'll ask you to keep an eye on the waiting room and keep admitting people while I'm getting started here.
Got it.
Thank you. Okay, so welcome everybody. Today's webinar is hosted by the Model Systems Programs and the Rehabilitation Outcomes Center at Spaulding. The brain, burn, and spinal cord injury model systems are federally funded programs that contribute to a really unique national database. We help enroll people at the time of their injury and then follow up with them to see how they're doing every 5 years for the rest of their lives. So when we talk about an outcomes center, this is the kind of stuff that we're really talking about. It's the understanding that these injuries don't magically resolve themselves just because the medical intervention course has ended or because insurance coverage has run out. So you can go to the next slide, Brianne. A central mission of the Outcomes Center and the model system is to create these types of venues where we can share knowledge, which brings us all together today. If you're interested in more, please scan the QR codes on the screen. We have a podcast where we have conversations with Spaulding researchers and people with lived experience. We have a webinar series that we did last year on the power of community organizations, and the links and recordings from those are available on our website, so you can scan that QR code for that one. And I urge you to sign up for our quarterly newsletter where we share information about community events, rehab research findings, and important news stories related to this subject matter. So please stay in touch with us and connect in any way that you can, because we want to keep putting stuff like this on. So thanks for being here today. You can go to the next slide, Brianne. We're thrilled today to have two of Spaulding's finest speaking with us. Jillian Chavez holds a master's degree in social work from Simmons University, and she's a licensed independent clinical social worker and a certified case manager. She's worked as both an inpatient and outpatient case manager, helping people to navigate the system at their most challenging times. She is the leader of the Community Partners Committee at Spaulding and has over 10 years of experience working with individuals with disabilities. Brianne Muchmore is also a licensed independent clinical social worker and certified case manager. She earned her bachelor's degree from Baylor and is a graduate of Boston College with her master's in social work. She has been at Spaulding since 2013 and is now the Senior Director of Care Management, overseeing inpatient and outpatient case management and social work services at Spaulding Boston and Spaulding Cambridge. Brianne also manages the complex case management program and has developed an innovative donor-funded patient assistance program called Supportive Surroundings, which provides financial aid and short-term temporary housing to patients who need it. The apartments are very adorable and very accessible, so it's a cool program to learn more about. In 2020, she also managed the case management teams at Boston Hope, the 500-bed field hospital for patients with COVID-19 and post-acute care needs. She's a board member for the American Case Management Association for Massachusetts chapter and a co-chair for the Education Committee. The two of these ladies were kind enough to take on our impossible task of addressing the insurance maze. It was too varied and broad of a topic for us to request, but we know that clinicians, families, patients, we all face similar challenges when we're trying to understand different types of coverage. So we hope that some of the basics that are presented here today will be useful for everyone in attendance. We hope to do one or two more of these sessions throughout the summer in the same insurance theme. So when this talk raises all kinds of questions for you, as I'm sure it will, please remember to fill out our feedback form at the end and tell us where we can focus when we pull together session 2. There's only so much we can cover in one session. So pay attention, ask lots of questions, and Let us know what you like to see next. So with that, I'll turn it over to Jillian and Brianne.
Thank you, Shonali. I'm actually excited to hear that you're doing some more of these, or there are more to come, because it was really hard to put everything we wanted to on these slides. We have, so many soapboxes that we could jump off of, and we're really kind of happy to kick it off. We want to thank everyone for having us here today and coming out to see and hear what we have to say and share. And we hope that, it is such a broad topic, and there's so many people from different, people who are living with disabilities or chronic illness, to clinicians and advocates in the field, researchers. It was really interesting to see how many people had signed up, and everyone's kind of, reason for being here. So we appreciate that. And it also gave us an opportunity to try to focus our thoughts a little bit on meeting kind of the objectives of everybody here today. So hopefully everyone finds this a little bit interesting and we get the conversation started. Brian, you want to switch should we talk about the objectives then? Okay.
Yeah, that'd be great.
So our objectives today are defining and understanding the differences between federal, state, commercial, and other types of insurance plans. We hope to empower patients and their families to proactively engage in their insurance journey, advocate for their rights, and ensure that they receive the support and services they need for optimal recovery and quality of life. And learn effective strategies for communicating with insurance providers, including how to access necessary medical treatments, therapies, and equipment. Next slide. So we have 4 main types of insurances that we're going to cover today. Commercial insurance plans, which are your employer-sponsored plans and individual market plans. COBRA and long-term care insurance plans. Federal insurance plans, which would be your Medicare and Advantage plans. And state-specific plans, which would be your Medicaid and other state insurance exchanges. So commercial plans are the ones that we all kind of get to know first. These are your employer-sponsored plans. They're private insurance plans. You can opt into them through either paying for it privately through an open market or through your employer. These plans are sold by private insurers, so their benefits often vary. For example, 2 employers may offer an HMO plan, but what they offer, and they might be, let's say, both through Blue Cross, but one HMO through Blue Cross might have a completely different benefit than the HMO from another employer. It just kind of adds to the challenges of working with each individual person and their plans. One plan might offer 60 days in acute rehab hospital. Another plan might offer 60 between acute rehab and a skilled nursing facility. So it just gets a little bit challenging. So it's important to know what your plan offers. There's also a different number of therapy appointments that might be covered. So we see a lot in outpatient. A patient might have 60 visits combined for PT, OT, and speech, and then other plans that might have 60 just for PT, 60 for OT, and 60 for speech. So it's just things to keep in mind when you're thinking about what plan you have, and things to start thinking about and questions to ask. Next slide. So COBRA allows for employees to continue their employer-sponsored health insurance coverage for 18 to 36 months after they leave their job, lose their job, or experience a reduced work hours. Employee has to pay the full premium plus the administrative fees. So these plans are often very expensive, especially at a time when people are experiencing high costs of health insurance, of hospital bills, medical equipment, maybe even home modifications. So it can be very challenging to keep these plans. Medicaid, something to keep in mind is that Medicaid often offers premium assistance for paying for COBRA, because it's cheaper for Medicaid to pay your premium than to be the primary payer for your insurance and your healthcare costs. Long-term care insurance, I just wanted to go back to COBRA real quick. You can, a lot of times, COBRA will tell you of 18 months on their plan. It's important to know that you can request, you do have to request it, it's not automatic, request an extension of 36, up to 36 months. So that's usually in writing. You just start that process by speaking to the COBRA administrator. So long-term care insurance was something that we got asked a lot in the feedback for registration. We see this less and less coming up because these plans are becoming kind of less cost effective for patients and families. Also for the insurance companies, they don't offer very many of these anymore because of the length that people are living, the high costs of long-term care, and also the benefits of them for patients. There's lots of fine print. So things to keep in mind if you're looking at a long-term care insurance plan or you have one already, keep in mind that there are coverage limits, meaning that there might be restrictions for where you can receive care. Some plans only cover skilled nursing facilities or care in a skilled nursing facility. Some only cover at home. Some might have a certain amount that can be covered at each one, or a total coverage limit. There might be a overall price that they're willing to pay. And then once you use that up either at home or at a skilled nursing facility, there's nothing left, and that those dollars can be used up very quickly. Another piece to keep in mind when you're looking at or looking at your own or looking for a long-term care plan is to consider the inflation protection particularly. So inflation protection in these plans, sometimes they offer it and sometimes they don't. So if you buy a plan for long-term care insurance that offers, let's say, $400 a day at a skilled nursing facility with no inflation protection, in 10 years, it could be $700 or $800 a day, but your long-term care plan is only going to be paying $400. So you have to come up with the difference. So that, again, can be very costly. There's another kind of piece to that, which are waiting periods. There's a lot of plans that require you to wait 90 days, 60 days, 100 days, and you're paying the costs of that care for yourself up until that point before you can even start making claims against your long-term care insurance plan. Next slide. Thank you. So federal insurance plans are that we'll cover today are Medicare in particular. So your Part A, B, C, and D. Part A is your general hospital insurance. Part B would be your doctor visits and outpatient care. And I'll skip over Part C for now, and that's Part D is next. So that's your prescription drug plan. Part A, B, and D is what is known as original Medicare. And that is because that is just your basic Medicare. That's the first one. That's what people think of when you think of Medicare. Part C is the Advantage plans. That one came into effect so that to try to lower the cost of Medicare. They thought that maybe private insurances could do it a little bit better. What we're finding is that patients are kind of pigeonholed into particular skilled nursing facilities, so they're not necessarily happy with their options that they have at the time of transfer, either from a hospital or into a skilled nursing facility, or you're subject to their in-network providers as well, where a lot of, at least in Massachusetts, most doctors, I would say, take take Medicare. The exception to that I've seen, that I've run into, is Florida, where not many providers take Medicare. I think just because there's a lot of people there that are on Medicare and they prefer the private insurances. The other kind of downside to the Medicare Advantage plans that we've run into is DME providers. So a lot of providers that are, connected to these Advantage plans that are national Advantage plans, maybe they're not covering that person's zip code, and the person didn't know when they signed up for that plan that they didn't have any provider for DME that would service any equipment that they get delivered to their house. So it can be a little bit of a challenge too. Next slide. Thanks. Enrollment in federal insurance plans. So if you have a disability, you may qualify for Medicare before age 65. The initial enrollment period is it begins 24 months after you start receiving disability benefits. So once you become eligible for Medicare due to a disability, you'll be able to sign up for parts A and B during the open enrollment period. And that begins 3 months before your 25th month of disability benefits and ends 3 months after your 25th month. So it's important to know that because it means that even though you have been approved for Social Security disability, you still have to wait 2 years before you're eligible for Medicare and insurance coverage. Next. State insurance plans. So Medicaid is a joint federal and state program. And because it is partly a state program, each state has its own kind of requirements around who gets coverage, how much money you're allowed to have, the assets limits. Those are all state specific. So we see a lot in our work in Massachusetts that we have a really great Medicaid program here where it's very robust. It covers a lot of people. But it's challenging when we have patients coming in from out of state and we're trying to figure out how to find what we have here where they live. It's not always available or easy to find. So each state sets its own eligibility criteria within the federal guidelines, and coverage can vary. With the exception of a handful of states, many expanded Medicaid eligibility for people who are with disabilities, which raise the income limit and assets. And it also allows for a lot of states to carry a sliding scale for premiums. Massachusetts Medicaid in particular, I know there's a lot of clinicians here from Massachusetts. The expansion of Medicaid also includes transportation, which we know as PT1s, and PCA program, which is the personal care attendant program for people who qualify for assistance for activities of daily living specifically. Some states offer state-specific plans that include initiatives or target small groups such as businesses or individuals with certain medical conditions or residents who face barriers to accessing healthcare. Just something to note as well. There's some states that do offer specific healthcare options for that. So it's important to check your state requirements. So we wanted to just kind of try to illustrate kind of what that might look like for a patient with a catastrophic injury who might be trying to figure out what is my insurance going to look like over the next few years. And it's challenging because everybody is a little different, and their situation, whether or not they decide to go back to work, when that might happen, what their employer offers might be a little bit different. But here is one example. So Jim is a 38-year-old male who suffered a spinal cord injury and has insurance coverage through his employer. Jim knows he will not likely return to his full-time job within the next 12 months, which is a criteria for applying for Social Security disability. He applies for Social Security disability based on the date of his injury, and in 24 months, he'll be eligible for Medicare coverage. That's 2 years. So Jim is offered COBRA through his employer and will request an extension of COBRA but beyond the 18 months. Once he hits, we usually recommend, at least in our world, around that 16, 17 month time to get that going so that you don't have any lapse in coverage. Jim learns that his state offers Medicaid to disabled individuals, and that may help pay for his COBRA premium because it can be very expensive. If Jim is eligible, Medicaid will become his secondary insurance to his COBRA plan. Just to note that Medicaid is the payer, what we call like payer of last resort. So they are always last in the lineup of all of the other insurances that somebody might have. Next. So Jim has been out of work for the last 2 years, and since his injury, he is now on Medicare. He starts working at a new job with health insurance. His Social Security payments will continue for his 9-month work trial period, and he will be able to keep his Medicare Part A for 8.5 years, premium free, as long as his disability continues to meet disability standards. His employer plan will become his primary insurance, and Medicare will be his secondary. If he continues to keep the Medicaid, that will either carry a premium now that he's returned to work, or he might feel like he doesn't need it anymore. It just kind of depends on what the cost benefit of that would be for Jim.
Great. Thanks so much, Jillian. That was great information, especially the case study, learning about Jim and how the real life experience relates to his situation. So thank you guys. Again, my name's Brianne, and I'm grateful to have the opportunity to take over the next portion of the next portion of our presentation. So this next portion, we're going to focus on understanding benefits and coverage. So as you can see in this chart, I won't read through it, but take a second to glance at it to understand some of the key elements of an insurance policy, things that we may hear or see, whether they're in our own insurance policies, in a patient that we're working with, or a family member. So this is a good grid to reference for the future when thinking about premiums, deductibles, co-payments, co-insurance, and how all of those connect with our insurance policy. We're going to talk about the different coverage plans from an insurance perspective, looking at inpatient, outpatient, and then what else my insurance may cover. So again, as Jillian said, many insurance policies are different and have, different aspects that can assist you and your family member during your care. So thinking about inpatient, what is inpatient? I know it sounds basic, but it's care that you are receiving when you are admitted to the hospital and you stay overnight or longer. So typically that includes, the hospital stay, room and board, nursing care, medications, but sometimes procedures and physician fees may be billed separately. So that's something to keep in mind when looking at your insurance policy. When we talk about levels of care, many of us may work in a particular level of care. So we think of level of care of the acute hospital. So a hospital like Mass General Hospital, Brigham and Women's, that they provide acute medical care to patients. The other level of care that insurances classify would be an LTAC level of care. So an LTAC is a long-term acute care hospital. Patients that are admitted to a long-term acute care hospital typically have very complex medical needs, such as ventilators, tracheostomies, transplant, significant wounds. The length of stay there is typically, longer, like 25 days or more, given the complexities of the medical conditions that the patient is experiencing during that time. There is rehab care also at an LTAC level of care, but the main focus is the medical piece. Another level of care that we often think about is IRF, inpatient rehab facility, also known as acute rehab. And acute rehab is determined that a patient requires, intensive medical coverage, but also rehab services, and that the patient can tolerate therapy 3 hours a day, up to 5 days a week. Also expected to make significant gains in a reasonable time frame is how Medicare describes it. So thinking about that the patient will progress very quickly. The length of stay in an IRF is typically 2 to 3 weeks, depending on the patient diagnosis. And then the lower level of care behind the inpatient rehab is a skilled nursing facility. So often we think of skilled nursing facilities. I think many of us think of nursing homes, but really skilled nursing facilities now provide short-term rehab, really have the abilities to manage complex medical conditions. But the patients are not receiving as intensive a therapy. They're continuing to receive therapy in that skilled nursing facility level of care, and also have daily nursing needs. So those are just a few, or most of the examples of inpatient level of care when we think about what our insurances are covering. We hear often, as a healthcare provider or a family member, we hear medical necessity, like, what does that mean? And so I think it's important to really understand when you're looking at the level of care that you or your loved one is in, what the medical necessity and what the criteria are to be in that patient level of care, like I talked about previously. So you'll hear often, like, my insurance policy covers me as long as medically necessary. And so I think that we often think, oh, that's indefinite. I can stay at Spaulding for 6 months. But actually they're looking at the level of care that we talked about, and that the patient is still expected to be able to make that progress and need that medical oversight for the medical necessity. And as Jillian mentioned, some insurance policy don't have the medical necessity clause. They have they have the medical necessity clause, but also a time limit of 30 days in a skilled nursing facility, or 60 days in acute rehab. So that's important to understand what buckets your insurance classifies to ensure to maximize the level of care that you're receiving during that time. Now we're going to transition to outpatient. So again, like it sounds, outpatient is something when you're not admitted to a hospital. Outpatient can be a medical procedure, it could be a doctor's visit, a test, something that doesn't require an overnight stay or admission to a hospital. So some examples like that we think about in our daily life, maybe a primary care appointment, a visit to physical therapy for a recent surgery you may have had, or even an emergency room visit without the admission. So now that we've talked about inpatient and outpatient level of care, there's a whole bunch of other things that fall under. So what else may be covered when we're thinking about insurance? Preventative services. So annual physicals, vaccinations, wellness programs. We're seeing more insurances now offer unique incentives for wellness programs, whether it's a fitness program and you can submit for reimbursement for a certain amount per person that has fitness plan. Recently, I saw an insurance policy that reimbursed for bike helmets, which I thought was such a great idea, especially working at Spaulding, where we see so many traumatic brain injuries. The insurance is better off, providing the reimbursement for this helmet than the latter of being admitted to the hospital. So it's really great to look at what your policy may cover. Sometimes those things aren't advertised, and you might have to dig a little deeper to figure those out, but there are some incentives to promote healthy living and preventative services. Prescription drug coverage, that is, we're thinking, our general CVS, brand name or generic drugs. Also, if you're looking at your insurance that will cover specialty medications, if you need any sort of IV antibiotics, sometimes that's under a different bucket. And another thing to think about when working with patients and or family members is mail order. So if someone isn't able to get to the pharmacy, getting your prescriptions in the mail is often covered, and or prepackaged. So they're in the prepackaged pill bottles, so they're not having to sort out every day opening pill bottles. So more and more insurance companies are covering those, and more pharmacies are offering that, which can be really helpful to patients in the community. Durable medical equipment, covers a lot of different things. Often we think of wheelchairs and walkers, but there's other equipment that may be more costly, such as prosthetics or bracing that a patient may need. We are seeing less and less insurance companies cover bathroom equipment. So that's often something that is out of pocket, or we'll talk about in a future slide, some resources that we can turn to when thinking about bathroom equipment. So what else we're still going through the list of what else is covered. Thinking about medical supplies. So does someone need oxygen? Do they need enteral supplies? Home care and hospice. So that gets tricky because there are a lot of qualifications that you need to meet in order to meet home care criteria. But generally speaking, if a patient is considered homebound and isn't able to get to an outpatient appointment and needs nursing or rehab care in the home, the insurance company will cover home care, also known as visiting nurse agency, in addition to hospice or end-of-life care. As Jillian and I well know, working at Spaulding, rehab services, so thinking about physical, occupational, and speech therapies, in addition to physician physiatry visits. Another piece that we may not know about is the catastrophic or chronic illness case manager. So many insurance companies will offer a case manager to help navigate all of these things that can be confusing and overwhelming as you're going through this process with your loved one or a patient that you're advocating for. So thinking about asking insurance companies if they offer that service and being able to utilize the case manager as a resource. Transportation. So you think about transportation, you think about emergency transportation, 911, ambulances. And then you also think, as Jillian referenced earlier, you think about non-emergent transportation, such as Mass Health in the state of Massachusetts is our Medicaid plan that does cover transportation through a service which we know as PT1. So it's good to explore with your insurance company what the transportation benefit is. And then, the last few things, although, this list is not limited, but, thinking about mental health and substance use treatment and services, alternative complementary therapies such as acupuncture, massage. There are things that our insurance will cover that aren't, what we think of as traditionally covered by insurance. So this is a lot of information. So I hope that this is helpful. But I'm going to continue on and talk about what to do and how to understand and maximize your insurance coverage. I know if you're like me and you're signing up for an insurance plan for yourself or for a patient, for a loved one, you're like, what does all this mean? Where do I start? So as daunting as it may seem, really focusing and reading the summary of benefits and the coverage plan by your insurance is really important, because there's a lot of hidden things in there, a lot of important things that we've talked about today that you will be able to see. So really focusing on reviewing those policy documents and reading the explanation of benefits and also the summary of benefits and coverage. ask questions. I think that sometimes this information becomes so overwhelming that we don't even know what questions to ask. So I would encourage you to not hesitate, to ask for explanation. Sometimes as healthcare providers, we use abbreviations or talk in language that doesn't always make sense to a patient or family member. So don't hesitate to ask questions and really truly understand what your insurance can offer. Think about, when asking questions, if what may require a pre or prior authorization. Often, procedures, in particular inpatient coverages and, specialized procedures will require prior auth. So you want to make sure that you have that in place before you go to the hospital to have that, or the doctor to have that procedure. Thinking about in-network versus out-of-network. So are your providers that you're seeing or hoping to see in-network with your insurance? Often, if they are in network, it will lower your out-of-pocket cost. So that's an important thing to be mindful of when looking at in versus out-of-network. And then understanding exclusions. So sometimes like certain elective procedures or what we may feel is necessary, but insurance company may deem elective may not be covered. So just be aware in order to understand, avoid surprises, be aware of what the exclusions may be. I feel like this is so much information. I hope that this is helpful, but please, feel free to drop questions in the chat and we can, try to cover them. We'll also have time at the end. So this slide I think is really an important slide because we're thinking about, thinking outside of the box. And that's something that I often, pride that my team does so regularly here at Spaulding is really thinking creatively, because at times insurance has limitations and restrictions. So what can we do to ensure that our patients and family members are getting the best access to care and maximizing their coverage? And so later you'll hear from Jillian about some more great case studies of how we can use advocacy and empower people to advocate for themselves. There are a lot of great community resources. I know that we have people from many states. I think that we saw in the registration that there were 15 states represented, which is exciting. Most of this information is specific to this on this slide is specific to New England, Massachusetts, where most of the registration people are residing. So resources for additional support. If your insurance company doesn't cover transportation, in your own state or town, there's often almost always paratransit options. So, there are great websites and tools to look up what transit options are in your community. For example, in Massachusetts, the MBTA also offers a service that we call the Ride that provides low-cost transportation for people with living in the community with a disability, whether it's temporary or life-altering at that time. They will cover that. That their ride is an option. So that's great. Thinking about if insurance doesn't cover, insurance doesn't cover home modifications. So many states have a home modification loan program. For example, in Massachusetts, it's a state-funded program for up to $50,000 that you can borrow from the state to do modifications for your home. So if you need to put in a ramp or a chairlift, you're able to access the home modification loan program. Foundations and different grants, your local case manager or person that you're working with in a hospital setting may be able to provide more resource specific, but thinking about some foundations and grants that may be specific to the diagnosis or injury. So for example, the Thomas E. Smith Foundation that will provide resources to persons with spinal cord injuries, the Brittany Fund, the Dream to Walk Foundation. There's many different organizations that have grants. Other organizations that offer resources, like United Spinal Association, Burn Survivors of New England. So depending on the diagnosis, even using Google to find organizations that may be able to offer resources. Equipment loan programs are really great. We often, as we talked about, bathroom equipment isn't covered very frequently at all by insurance companies. And so you can purchase it at Amazon or your local Home Depot or Walmart. But there also are equipment loan programs where you can go and people donate and recycle the equipment for free. Also, people often see on like their local community pages on Facebook or their Facebook Marketplace, there's other options for patients that may not be able to afford their equipment. Again, there's so many great resources, but thinking about independent living centers often provide skills training, housing advocacy, also have transportation resources, and then local or state funded programs, thinking about like elder services, Meals on Wheels. So there are a lot of great options outside of our insurance, just thinking creatively to maximize what's available in the community. So I was going to show a video, and I was actually most nervous about the technology piece of sharing the video. But since we've shared so much information, we're not going to have time for the video today. But I did want to just share, and it will be in the slides if you wanted to look at it later. But just thinking about this information is a lot. It's a lot of details. It's a lot of, will it cover this? Won't it cover that? But just taking a pause and being able to recognize and empathize like the human connection to all of this. Behind every insurance policy, every procedure is a person with a life. And as healthcare providers or family members, being able to empathize and recognize what this person is going through as they're trying to advocate for this service can get us a long way. And so I loved the quote by Henry David Thoreau: "Could a greater miracle take place than for us to look through each other's eyes for an instant?" So really being able to empathize. In the video that you'll see in the slides later is very few words, but just talks about and goes through the hospital, showing what people are going through and the experience that they're encountering, and really gives us a moment to empathize on what life-changing, traumatic injuries or illness people are facing. So advocacy, I think that, that's if you take away anything from this slide is, or from this presentation, is ask questions and advocate for yourself or the patient family member. Being involved and having proactive engagement with your insurance company, thinking about different ways to advocate for, and Jillian will talk about those in her case study. But thinking about our local ombudsman office, the Executive Office of Health and Human Services, utilizing state reps. Is your insurance policy self-insured? So lots of questions to ask that Jillian will dive into further in our case study, which is, I think, next. So Jill, we'll have you talk about Bob and share some more great examples.
Thank you, Brianne. So I think one of the things that Brianne touched on just now is really kind of focusing on what are the ways that we can advocate for ourselves and for patients that are effective and also kind of outside the box. What I've learned from patients, and I often come into work and I kind of wonder what patients are going to teach me that day, because I learn a lot from the advocacy of my patients' families, from themselves, and even just trying to figure out how to, fit a square peg in a round hole. So one of the case studies, this was taught to me by a patient's family member who just wouldn't take no for an answer. And it's wonderful that she did, because I've been able to use this for a lot of other patients and help other people advocate for themselves. So Bob was injured outside of work. He was over at income and assets to qualify for Medicaid based on the state's guidelines without a cost-prohibitive premium. His employer-sponsored health insurance did not cover the number of daily catheters to meet his needs. Bob was able to speak with his employer, who was able to request a single employee exemption to increase his coverage through the insurance broker. So it's not always that simple. For this person, it was, I believe that it ended up being a plan that his employer was self-insured. So we often see patients that are that have employers who create their own health insurance plan for their employees, and they often have some leniency in some of that. But we have seen patients who, since this example, have been able to even just talk to their insurance, their employer, to ask for this single case agreement, essentially, for an exemption for this person who does have a catastrophic injury. Often insurance companies have loopholes within their plans. Examples of this might include increased catheter supply limits if a patient has multiple UTIs within a certain period of time. Another might be if a patient needs a bariatric hospital bed but doesn't meet the weight requirements, which are usually pretty strict. We've seen patients get qualified for this based on their girth, measuring that instead, and justifying the exemption that way. It's also important to mention that learning about opportunities for exemptions may not always come from the insurance provider themselves. Sometimes we learn these things, and oftentimes we learn these things going directly to the DME company that is, or the supplier that's providing it, and saying, how do I get this covered? What do I need to know? What would qualify me for this if I don't have this one requirement? What do I need to prove? And going that way, because the billing departments often have, know all the ways to get things approved based on their experience as well. Our next one, Brianne. So Mark has been on Cobra since his initial injury, his initial spinal cord injury. He had been progressing towards ambulation and driving when he had a gradual increase of pain, which left him bedbound. He lived in a rural part of the state without many options for specialized care and had been hospitalized for pain multiple times over the course of 6 months. He was no longer able to tolerate sitting without severe pain and had no way of getting to specialized care 2 hours away. Mark worked with his primary care provider, a specialist in the city, and a catastrophic injury nurse case manager to advocate for non-emergent ambulance transport covered by insurance. Mark submitted his emergency room visit documentation, the radiology reports, to his primary care provider, who submitted this to the utilization review department with a letter of medical necessity stating the reason he needed to be seen by the recommended specialist and reason for ambulance transport. This has now been approved multiple times to ensure Mark is obtaining the care he needs. When I wrote this out, it sounds so easy. The reality is that the documentation that the insurance requested, I faxed 4 times to the utilization review department before it was formatted in a way that they would accept. It had all the details that they requested, just not in the way they wanted it. We've been able to get this approved multiple times, as I said, but the process that the utilization review department gave us the first time was not the same the second time or the third time. So every day the rules are kind of changing, and it just kind of depends on the person you get on the other side of the phone, the person who picks up the fax when we fax it. But the point that I'm trying to make is that it can be incredibly difficult, time consuming, but giving the patients the chance to regain his quality of life is worth it. And it's something that we work at every day in outpatient. And I know you all are working very hard every day to do as well. So I guess the next question is like where to find help. And I think I saw this come through the chat as well. So when we're looking at where do we even start with figuring out what insurance we need, a Shine counselor, or it's also called SHIP, is a program that is offered at every state. It's a federal and state program that offers insurance counselors that are certified to help patients enroll in Medicare and Medicaid, trying to figure out what plan works for them. It's not just for the elderly, although you often find them in elder service agencies or at elder service agencies. So, but they are state funded, federal funded, and they are certified in helping you figure out your Medicare and whether or not you will qualify for Medicaid. Insurance companies often have catastrophic injury case managers, nurses, or social workers to help support their members. So when you're trying to figure out, you're looking for someone who's more specialized in SEI that might understand the insurance better, it's good to ask for a nurse if they have that option, like a case manager, a nurse, a case manager, nurse, social worker who is available to you, especially, it might not be a catastrophic injury. It might be someone who's a high utilizer of hospitals or their benefit, or you might qualify in different buckets based on kind of your injury, illness, or utilization of the insurance plan. Primary care providers, there's often social workers and case managers at larger practices that can offer some insight into, where to go from here and some information on that. Next is our conclusion. So we hope that you were able to take some of our tips and tricks away, and just really learning that thinking outside the box, not taking no for an answer. Oftentimes, if you call back any insurance company, not just Mass Health, you can get a different answer depending on who picks up the phone. They're maybe willing to give you more information than the last person you spoke to. And also just understanding that you have appeal rights. There is a process to follow, and just because they say that's the end of the process doesn't mean it is. We've seen a lot of patients be able to advocate for themselves and move the review past the final one. So just continuing to try is it's a lot to ask when you already are dealing with so much in your daily life, and trying to get better and stay well, but it's worth trying. Any questions? Shonali, do we want to go to questions?
Yeah, that would be
Okay.
great. And actually, maybe we can, Brianne, maybe you can stop sharing, and people are welcome to come on camera if you're comfortable. There are some good questions in the chat, and we've got about 5 minutes, so we'll try to pop through them. There's a lot of really good and very difficult questions in the chat, I will say. Maybe we can start with, I don't know if you guys have answers to all of these for sure,
Okay.
but any tips on home modification programs that don't cost the price of your mortgage?
So a lot of these are state specific. So in Massachusetts, we do have what's called the Home Modification Loan Program. And what that essentially is it offers a 0% interest loan to a patient or a person who needs to modify their home to access a bathroom, kitchen, entryway, anything that might be related to their disability. And they don't have to pay back the loan until they sell their house. So that's really the only criteria at the end of that. So there's nothing, it's again, 0% financing. So nothing upfront that's at a cost to you. There is a financial piece to that. So I think, it's fairly generous or reasonable. I think it maxes around $300,000 income for a single person, goes up a little bit for someone who is married. So that's the one I know of in terms of Massachusetts. I imagine there might be other ones for other states, but I'm not familiar with where.
Yeah, and we'll ask also that, especially during this last component, if other people, non-presenters, have thoughts or ideas on answers to these questions.
Yeah.
Like Jillian said, we like to learn from everyone, so feel free to chime in. Abby has some very hard to answer questions on here, but let's start with maybe, which is the slightly easier one, which is how to find the right person when you're talking to the insurer, right? So sometimes the person who answers the phone at the insurance company doesn't know much about spinal cord injury in this case, and the caller doesn't really know anything about codes or categories. So it's like speaking different languages, and Abby was very grateful to have Jillian's help translating during her time. But yeah, do you want to, I think maybe Shine is the good, but go ahead and anybody can speak up about.
Yeah, I would just say asking for a case manager from the insurance to kind of help, mix the two, because oftentimes those nurses, they started in a hospital setting, they might have started in the medical, they started in the medical field. So, and kind of crossed over to insurance. So I would start there, see if you can access a case manager through the insurance company. And then, Brianne, do you have other thoughts of where to kind of go next if you don't have a me?
I think, yeah, no, I think even if you have a Jillian or an expert that's working for you, it's just a matter of being persistent. I would keep records of the conversation that you had. Don't hesitate to escalate, in a patient, polite way. Of course, I think that helps us to get where we need to be. But really being focused on until you get a yes, keep pursuing and being persistent with asking for other people to speak with. But I know how frustrating it can be when you're on the other line and they just don't get it.
And I'm gonna call out Abby's other comment, which I'm gonna say is more of a comment than a question, because I don't know that anybody here knows the answer, Abby, but can we talk about the reasons why we're seeing shorter and shorter private insurance approved stays at acute rehab hospitals like Spaulding? Patients don't seem as ready to function and improve upon discharge as they should in terms of skills, strength, etc. Sometimes their home continues to be inaccessible, even if they've started work right away to improve it or find another place. Are insurance companies aware of the potential impact of short stays on long-term costs? Do they hope patients will be another company's problem by then? Do they truly think that discharge to a nursing facility or to a home that may not be in a good location, like within reach of paratransit or in a rural area, for getting to outpatient therapies results in equally good outcomes? I don't know. My main response to that is that I think we're all seeing this as a problem, and there are, of course, we've learned over time benefits to recovering in the community, but that's not really what you're talking about in this case, I think. So I don't know. Anybody on the call have any responses to that? We got to engage more with payers to understand the processes and the systems.
Yeah, I think, Abby, thank you for that comment. There's a lot of information that we could talk about just in that, comment alone. I think, if I look at it from the positive perspective, we're seeing that more different levels of care can accommodate more, so for example, skilled nursing facilities can take more complex medical conditions. We have programs like home hospital programs. We're seeing home health and VNA agencies being able to manage more in the community. So I think that like we felt that. I think that anytime you open the Globe or turn on NPR, you're hearing about the access to beds and throughput. So there is a constant pressure to keep moving patients through the system because of the beds that are overcrowded. But yes, you make huge points about, other resources that we need in the community. I'm biased, but Spaulding has a great donor funded assistance program that is truly funded by donors that allows us to provide shorter term solutions to some of these problems when homes are inaccessible, but that's not everywhere. And so we need to continue to advocate and use our voice. And Abby, I don't see you on here. I see your name, but I'd love to meet you sometime and chat further about your experience. Seems like you have good advocacy.
Abby's a rock star. So I know we're at one past. So if people do have to drop, know that this will be recorded, and I'm going to try to actually get it up to YouTube. So that might take me a couple of days, but know that you will get an email with the recording and the slides Brianne's email address is in the chat too, if you want to reach out to her. And if people are able to stay on for 2 more minutes, then we'll finish up with Lewis's question, which is clearly from a data guy, which is, are there any computer-based systems that can provide the best approaches to maximize level of care over a period of time so that the clinical social worker can make use of?
Thank you all. Yeah, so I mean, there's programs like such as like Interqual that really focuses on levels of care. I am eager and curious to learn about different AI models within healthcare. I think we're a little bit behind on that right now, but I'm curious to see in the coming months and years what models we can use. I was at a conference recently and they showed an example of a software company that like called a family member saying like, hi, you know, I'm so-and-so, and I'm talking about skilled nursing facilities. A skilled nursing facility is, and like really outlines like the basics, and was able to like generate an AI generated list to the patient and family, like, which, you know, if you think about clinical time, that, you know, putting the list together and what have you. So there are a lot of things coming out, but we have a lot of work to do still with looking at levels of care and maximizing it.
Yeah.
I have a quick question.
Yeah. Pam.
So just going back to the idea that there is a human behind all this, right?
Yeah.
Representing burn survivors of New England, we really see the humanistic side of our survivors. And we're talking a lot about these resources. And of course, we can't wait until AI comes out with this whole like recorded skill set of where to go. So I guess my question is, in order to serve our community, is there like a cheat sheet? Do all of you that are within these hospital settings, because the biggest thing that we hear is no caseworker and they're just left alone. Some of them don't even speak English. But is there a source that we can be provided possibly to myself where I can add it to our website or be able to guide in that format rather than, you know, send an email and say, I heard this, you know, this webinar. Is there a way that you all have a cheat sheet that you follow and kind of like this progression? There were some great resources mentioned in this webinar, but I wouldn't have known that if I didn't show up.
Right. I think that is like part of the challenge. And it's something that Brian and I talk about all the time is like, you know, how do you define what we do as outpatient case managers at Spaulding? And how do you kind of make it more equitable and reach more people? And I think that's one of the hardest things that we have is because we have, you know, each of one of us have been an outpatient for a long period of time. We've been in the field for a long time. It's really hard to, because some of the programs are based on where your primary care is located, where you get your outpatient therapy, where your specialists are, you know, how old you are. There's so many things that are based on things that we can't generalize, that it is very patient specific. And it's certainly job security for me, but I do wish that I had a way to kind of share, you know, that reach more people in that way and more generalized.
Yeah, and that tags on to Abby's other request of whether there's a good general dictionary of insurance terminology.
Yeah.
So we'll see what we can pull together.
Yeah.
Thank you, everybody. Brianne, Jillian, any final words?
No, thank you all for everyone's engagement and involvement, and keep advocating, whether you're advocating for yourself or a family member or for a patient. This is a great forum to be able to do that. So thank you all. I can feel and hear the advocacy in your voices and your words. So thank you.
Thanks, everyone. Make sure to fill out the feedback form and let us know what we should follow up with for a second session. Thanks,
Great.
guys.
Thank you.